Now I'd like to invite, it's our pleasure to have Dr. ADITYA KELKAR here. He's Director of AIOC Pune, and he'll be talking to us about the real world outcome with extended vision IOLs in an Indian population.
Thank you, Dr. Ritu, for this kind introduction, and thank you, organizers, for having my talk here. So, I'll be talking about my experience of using this VVT IOL. As you may be knowing, I do a lot of retinal surgery work as well. So, it so happens that probably it's now in my blood to under promise and over deliver. So, probably that's why one of the reasons why I find this lens extremely useful as well as very satisfying for the patients. So what patients exactly want is that they want to drive without any glare and halos. They want to have a good time while watching the TV. At the same time, watching looking at their phones, or when they go shopping, they don't want to depend on the glasses to do their day-to-day activities. So these are the basic requirements for any patient who would be suitable for a EDOF lens, and which, in my opinion, is probably each and every patient probably has these requirements nowadays, because reading as such has reduced quite a bit compared to how people in the past they used to read. Now everybody's on the phone most of the times. So how far we have come? Initially there was monofocal, and the dependency on glasses was the question, and so people moved on to multifocal glasses lenses, and then there were issues with the halos and glare, and then came the EDOF to find a solution, something which is better than multifocal. So talking about EDOF, there are different types of EDOF lenses and different technologies being used. One of the common technologies is obviously the small pupil aperture EDOF lens, but it's a lens that has a very simple principle like pinhole effect, but at the same time it's more light dependent. So if the light is reduced, these patients can suffer from difficulty in low light conditions. Then came the Symphony lens, or the EDOF lens, which was based on diffractive echelette design, which kind of stretched the wavefront, and in order to achieve the multifocality gives rise to some kind of halos and glare, even though it has fairly good spectacular independence that you can achieve with this lens. And because of the halos and glare being still an issue with the extended depth of focus lens, then came a novel idea from Alcon about the VVT lens, which uses the proprietary X-wave technology. So it has so how it exactly is different from the monofocal intraocular lens is basically it stretches and shifts the wavefront compared to how the diffractive multifocals use the principle of having multiple foci using diffractive or refractive technology, and that's why the halos and glare is much less compared to the other lenses. So if you happen to use this lens for the first time, when I used this lens for the first time, I was dialing the lens in the bag and tried to rotate it to the axis that I wanted, because this was a toric lens that I was using, and I thought it's exactly the same as the accuracy of IOL. So I looked at my assistant to confirm that this is exactly the VVT lens that I am using, because it has a very subtle bump in the center which may not easily be picked up in the initial few cases. Then I saw in detail after tilting the eyeball a little bit, then you see a small impression of this central halo. So what it does is that there is a small elevated plateau about 1 micron that stretches the wavefront, and then there is a 2.2 millimeter region in the center that kind of shifts the wavefront to utilize all the available light energy. So without compromising on the amount of light that enters the eye, this wavefront is stretched, and so we get a seamless vision without much dependency on the glasses. So that's the principle of this intraocular lens. So stretch and shift, but it does not split the wavefronts, and that's why the glare and halos are much less compared to the other types of EDOF lenses. So the difference between the different variety of lenses, the monofocal lens, the trifocal lens, and the EDOF lens, that's where exactly the EDOF lens with VVT currently lies. So it has better vision experiences, but less amount of halos and glare, as well as the quality of vision can be comparable to the monofocal vision. So the patients who have difficulty, I mean, already are driving at night, do not want any halos or glare, and more dependent on computer-related technology for their work-related work issues, are the best candidates for this type of IOL. So somebody who's in their 50s or 55-year-old and who is currently working in a, say, IT industry would want to use the computers most of the day and probably travel back at night for driving about 10 to 15 kilometers in his car might find this lens much more suitable compared to a multifocal intraocular lens, which can have halos as well as glare in many of the patients. So coming to the near vision acuity compared to the multifocal IOLs, yes, it has a slight compromise on near vision when it comes to fine reading. But again, as I said, the number of hours that you spend reading fine print nowadays is much less than probably in the older days. So the successful integration is possible only after you have understood the criteria of selecting these patients. So obviously age and relative presbyopia, pre-existing refractive error, ocular conditions, corneal refractive surgery, personality types, the visual needs, profession, lifestyle, the status of the current lens, and the type of visual compromise and the surgically associated risks are the criteria that you need to consider before implanting this lens. At the same time, at the moment, I do not encourage the patients who have a severe dry eye or those who have other pathologies like macular degeneration or corneal pathology or uveitis to go for these type of lenses. Right. So the A constant that we use for the optical biometry is 119.2. That is something that you need to take into account. And also the results that we have got by now is we have an experience of more than 200 lenses that we have used so far. And we conducted a study of 140 eyes with 70 subjects who finished 6 months follow-up. It's a retrospective study. All the patients achieved good intermediate as well as distance vision, and we were quite surprised with their near vision abilities, and almost 40% of the patients were comfortable without glasses for all the near work. 10% required only plus 0.75 when they wanted to do fine work, and about one diopter in about 27% of the patients. So roughly if you see, approximately 75% of the patients are relatively free of glasses when it comes to even the near work, whereas 13 to about 25% of the patients required 1 to 1.5 diopters of correction for near work. The limitations for this technology are the bump that it has in the center. In patients who have a very small pupil may experience slight myopic shift, so you have to see how the first eye is behaving and then probably plan the other eye after you have ensured that the refraction in the first eye is bang on. So with that, I once again thank the organizers and Dr. Ritu for having me here. Thank you.
Thank you, Dr. Aditya. That was really nice. I've had some experience with Vivity. How do you plan your post-op target refraction?
Yes, so what we do is target emetropia for distance vision when we do the first lens, and if the patient achieves good distance vision, then only we go for slight undercorrection for the other eye. That way you can have more independence from glasses.
But slightly, you mean on the myopic side?
I go a step down. So for example, if the patient's IOL power is, say, let's say 22, I would rather prefer slightly lesser power, which is towards myopic side. The first myopic power than 0.
Right.
Can I, Doctor?
Yes,
you said you're a retina specialist, and you said that you don't. I mean, it's an exclusion criteria. All retinal disease, or
no, the patients, for example, who have got wet AMD, they are likely to have anyway poor vision. So these expensive lenses, I wouldn't really encourage them to have. But somebody who has drusen, I would still go ahead with it.
Yeah, because I mean, since there is no distribution of light, and we are not going to affect the contrast sensitivity, I see no reason why we shouldn't put it in mild.
Suppose the patient has corneal scarring, there is a chance that he may have additional halos and glare with this lens.
No, these are quite forgiving lenses, and if your biometry is a little bit way off, also target, patients can still have. The only thing is the distance vision may be slightly less than what you would get with a monofocal. So there's always a trade-off in all these lenses between, you know, your range of vision and of course the focus.
So all said and done, I think this lens is really good when it comes to when you want to counsel the patient. For example, when you talk about multifocal lenses, what patients expect is definite freedom from glasses, whereas in these lenses you are already telling them that you are likely to require slight reading glasses, and they are happy to accept it post-operatively. So as such, as you said rightly, it's more forgiving because it actually under promises and over delivers.
Yeah, at the same time, if you counsel them preoperatively that for reading, just use a little bit more bright light. That often helps them to read much
That's
better.
right.
Yeah.
So what I feel is that these modern monofocal intraocular lenses that were introduced before this VVT lens, they probably overpromised the intermediate vision. They are as good as monofocals in my opinion, whereas this one is very close to multifocals when it comes to spectacle independence and very high on patient satisfaction because the halos and glare are much less.
Absolutely. Very safe to go to. So if you're going to start off your multifocal practice, then best is to start off with